multiple nodules which are involving the upper and the middle zones, as we mentioned earlier. If the disease mainly involves upper and the middle zone, then it is highly suggestive of sarcoidosis and silicosis and other conditions. Bronchiolitis obliterans can also be diagnosed on plain X-ray chest by patchy ground glass opacities. You can also have linear reticular shadows or round or nodular shadows in some cases, but in majority of these cases you can have multiple opacities which are peripheral consolidation like pictures, which can come and go with the opacities may last for few weeks, and if you repeat an X-ray after some time, you may find a similar opacity coming on the other side. Then in some cases there can be a diffuse involvement of both the lungs. This is an atypical presentation of bronchiolitis obliterans. In some cases there can be solitary or multiple alveolar nodules in these cases. So there is ground glass opacification, which can be segmental or lobar in location. The shadows may wax and wane, and there can be a diffuse reticular nodular infiltration. This is a case of bronchiolitis obliterans. Here you can see diffuse reticular nodular shadows along with cystic changes involving both the basal areas. X-ray chest is also important in diagnosing sarcoidosis, not only in the diagnosis but also staging the sarcoid disease. The disease can be staged as 0 when the X-ray picture is normal, stage 1 when only the mediastinum and the hilar lymph nodes are involved, stage 2 when the hilar and lymph nodes along with pulmonary infiltrates are involved, and the stage 3 where only the lung involvement can be seen. So you can see here in this X-ray there is a mediastinal widening, there are right paratracheal glands, there can be subcranial glands, and you have bilateral hilar gland. So this is a stage 1 sarcoidosis. Here you can see again bilateral hilar glands along with parenchymal opacities. This is stage 2 sarcoidosis, and here the lymph nodes have practically regressed, although you can see some opacities in the hilar region, but mainly the disease involving both sides on the upper zone, suggestive of advanced sarcoidosis stage 3. This is a atypical sarcoid where you don't find any lymph nodes, and you see a diffuse disease which is involving mainly the basal areas. So as we have already described that in sarcoidosis the parenchymal involvement is mainly in the upper lobe. In such circumstances, histopathology plays an important role in the diagnosis of the disease. The pulmonary eosinophilic granuloma, this is again a disease which involves upper and mid zone of the lung. You can have both reticular and nodular shadows, and you can have honeycombing. In this disease you can also see multiple cystic shadows along with an evidence of pneumothorax in some situation. Here you can see again a picture where you have multiple cystic shadows, maybe some nodular shadows also can be appreciated, and you can see that the lung volumes are well preserved and there is an evidence of pneumothorax. This is a typical X-ray of eosinophilic granuloma. This is another case where you can see small cystic shadows on both the fields of the lung. Another important condition which can be diagnosed on X-ray chest is lymphangioliomyomatosis. Here you can have evidence of hyperinflation. The lung fields are either normal in size or they are increased, as against other interstitial lung disease where there is an evidence of volume loss. You will see cysts, you can see bulla, you can see pneumothoraces and reticular nodular shadows. There can also be presence of pneumothorax or pleural effusions. So this is a picture. I think it is little difficult to appreciate cyst in this. Here you can see in this we can see multiple cyst like opacities on both the lung zones. The same patient later on presented with evidence of pleural effusion. So on the basis of X-ray chest, you can make some differential diagnosis. If the patient has present with acute problem, then this could be due to pulmonary edema or pneumonia. Those interstitial lung disease who are associated with pleural effusion on plain X-ray suggest very highly the differential diagnosis of pulmonary edema, lymphangitis carcinomatosis, lymphoma, and collagen vascular disorders. Evidence of pneumothorax strongly suggests LAM and eosinophilic granulomas. And if the disease is associated with significant volume loss, as I mentioned to you, which we see in most cases of interstitial lung disease, it is highly suggestive of fibrotic interstitial lung diseases like IPF, collagen vascular disorders, silicosis, asbestosis. Mainly middle or the upper lobe involvement, the conditions are sarcoid, silicosis, and Langerhans cell histiocytosis, and the conditions which are associated with lymphadenopathy are the one like sarcoidosis, neoplasms, infections, and silicosis. If you have an evidence of pleural thickening or calcification, again it is highly suggestive of asbestosis. So what is the role of HRCT? Now HRCT is far more superior to X-ray chest in the evaluation of interstitial lung diseases, because it gives us a much finer details of the gross anatomy of these patients. The changes which were described by Dr. Sain in histopathology can be very nicely delineated in the HRCT. We can very nicely define the secondary pulmonary lobules. We can look into the interlobular septas. We can look for the distribution of the disease. We can look for the involvement of the central area. We can look for a specific involvement of the lobule, whether it is a panlobular involvement or it is a paraseptal involvement or it is a centrilobular involvement. We can also get some idea about the activity of the disease, and we can also look for the response to therapy in these cases. And in some cases, by looking into the HRCT picture, we can also anticipate the response of therapy, whether this patient is going to respond to anti-inflammatory drugs or not. It can also help us in choosing the right site for histopathology. Although in idiopathic interstitial pneumonias, the various HRCT patterns are diagnostic and histopathology is not required in majority of cases, but there is a subgroup of these patients, these conditions, where biopsy becomes mandatory to confirm the diagnosis, and in this situation HRCT helps us in choosing the right site for taking these biopsies. Now we are looking into the important radiological patterns which we see in various interstitial lung diseases. Those conditions which are associated with patchy, bibasilar, and subpleural conditions, and mainly involving the lower areas, they are the IPF, ILDs, which are associated with CVDs, the central, perihilar, and upper zone involvement associated with adenopathy we see in sarcoidosis, and then there are conditions in which there is no particular predilection for a particular zone. There is a diffuse involvement, and there is a patchy and ground glass appearance along with nodules. These are the conditions which are associated with granulomas, and these are the conditions which are associated with involvement of the airspace. And of course, the cystic lesions which we see in lymphangioliomyomatosis and histiocytosis X. So I'll show you some important examples in these conditions. Now these are the ground glass appearances which you can see in some cases of interstitial pulmonary fibrosis, and once these patients are treated with steroids, later on you can see a classical reticular pattern which indicates the residual fibrosis in this situation. This is again another case of interstitial pulmonary fibrosis indicating subpleural and basal involvement in the form of a ground glass opacity and a reticular pattern. This is another patient with reticular pattern. Here you can see. Now this is the classical reticular pattern with no ground glass opacity, indicating severe form of interstitial fibrosis. This is an advanced interstitial fibrosis with typical picture of honeycombing, which you can see again a honeycomb lung with multiple cyst formation, indicating advanced disease of condition of interstitial fibrosis. Non-specific interstitial pneumonitis is a another variety of interstitial pneumonia. They are variably associated with a combination of ground glass attenuation and reticular pattern. The component of ground glass attenuation is much more than the reticular pattern in this condition. The important differentiating feature in this condition is the absence of honeycombing. The another very important thing here is asymmetrical involvement of both the lungs in this. You can see here again a patient with the bilateral diffuse involvement. This is mainly a ground glass pattern. Now this is a picture where you can see a subtle ground glass appearance is there. Along with this you can see a reticular pattern in the basal, but there is an asymmetrical distribution of this reticular pattern as against usual interstitial pneumonia, where you see there is a bilateral symmetrical pattern. Now this is a condition which is usually associated with smoking. In this we have two categories. One is respiratory bronchiolitis associated with interstitial lung disease, and other is a desquamative interstitial pneumonia. Now this is basically associated with cigarette smoking, and there is involvement of the small airways. In RBILD, there is mainly an involvement of the peripheral airways, and there is sparing of the interstitial, sparing of the alveoli. But in cases of DIP, there is involvement of both the small airways and the airspace in the surrounding area. You can see here a diffuse ground glass pattern, and you can also see paraseptal emphysema here, indicating changes due to cigarette smoking. In other situations you can also see a subtle areas of low attenuation along with thickening of the interlobular septus. So this is a typical pattern which we see in cases of respiratory bronchiolitis interstitial lung diseases. In cryptogenic organizing pneumonia, again you can see here bilateral here you can see patchy peripheral involvement with air bronchogram, dense opacifications. This is another picture. Here again you can see peripheral patchy involvement on both the lungs in the subpleural areas, along with some areas of ground glass opacities. This is another area, case of cryptogenic organizing pneumonia, where there is an involvement of both the lung zones and the basal areas, and you can see that there is an evidence of reticulation in this, indicating significant presence of fibrosis. Acute interstitial pneumonia is another variety of interstitial pneumonia. Here you see there is a diffuse involvement of both the lung zones. The picture is very much similar to ARDS. The only differentiating feature from the ARDS in these cases is the presence of reticulation, the presence of traction bronchiectasis, and the presence of fibrosis. So as Dr. Sen has mentioned, that there are two stages, the initial exudative stage and the later proliferative stage. In the proliferative stage, you can see the evidence of reticulation, fibrosis, and traction bronchiectasis. Sarcoidosis, the clinical, the HRCT pictures are very characteristics. It is basically the involvement of the central bronchovascular bundles. You can see that they are thickened. There are nodular shadows, so it gives a beaded appearance of the centrovascular bundles. There is also involvement of the subpleural areas with the nodules, and there is an involvement of both the lungs and mainly involving the upper zones. So this is the classical picture in cases of sarcoidosis. These nodules, these shadows can become much bigger. They can coalesce, can form a diffuse opacification, again involving the central areas of these lungs. Again, you can see here there is involvement of both the central bronchovascular bundles as well as the subpleural zones. This is the typical presentation CT picture which we see in patient with sarcoidosis. Again, another patient with central bronchovascular involvement along with calcification of the lymph nodes here. This is a case of miliary sarcoidosis. Again, you can see the presence of bilateral multiple nodules. And this is a case of stage 4 sarcoidosis where there is a destruction of the lung parenchyma, and you can see the cyst mainly present in the central bronchovascular bundle. So I have basically tried to cover the important conditions here, the HRCT patterns of various interstitial pneumonias. And it is important that when you are evaluating these patients with imaging, you have to take into account certain important features, that HRCT is a diagnostic in certain interstitial lung diseases, particularly idiopathic interstitial pneumonias. In interstitial pneumonias which is associated with known causes like drugs or corrective tissue disorders, the role of CT scanning is basically confirmatory and to rule out other associated conditions like infection or malignancies. So, but there are certain limitations of HRCT which should not be forgotten, and wherever you feel that HRCT is not able to provide the right diagnosis, it is important for us to consider these cases for biopsy, and in these conditions HRCT helps us to locate the proper site of biopsy for final histopathological diagnosis. Thank you.
Topic of this session was imaging in diffuse parenchymal lung disease. Expert was Dr. J.C. Suri, Head of Department, Respiratory Medicine, Safdarjung Hospital. Thank you so much for coming and participating in this Gyan Darshan teleconferencing program, Doctor.
Thank you.
Viewers, this program was jointly conducted by Indira Gandhi National Open University and National Board of Examination. Now it's time to close down. I, Sangeeta Sinha, will take your leave. Stay tuned with Gyan Darshan for the next session of this teleconferencing program.